A patient is brought to the emergency department in the cardiac arrest. The monitor shows that he is in ventricular fibrillation. The paramedics have already given 3 cycles of cardiopulmonary resuscitation and intravenous adrenaline. You decide to give amiodarone. What is the correct dose of amiodarone to give initially? I totally don't know, so I'll just have to guess. 1 or 10 or 100? 10. 300. So that shows that we need to study about adult advanced life support. Okay, so go on. It's worth knowing these things because in case of emergency, you can't look up the doses. You don't really have time for that. Okay. Nope, this is the wrong one. That's more advanced life support. Okay. I have to delete this so that I don't open it accidentally next time. Or this transition. Okay. So let's look at what Resus Council UK says. So this is the guidelines on the adult advanced life support. Here are the authors, the guideline process. Oops, accidentally clicked that. Okay, let me just change it a bit. View, continuous scroll, right? Why do when I make it full screen, it's no longer continuous scroll? Can I change that? Oh, just read it like this. Then. So this is what Resuscitation Council UK says. This is a guideline process. Summary of the changes. Introduction. Okay, this section on adult advanced life support ALS adheres to the same general principles as guidelines 2010. This is guidelines. When is this dated? Is there a date on this document? No date. Okay, it's 2015. Okay, not that updated. It's like 6 years ago. Okay. This section on adult advanced life support ALS adheres to the same general principles as guidelines 2010, but incorporates some important changes. The guidelines in this section apply to the healthcare professionals trained in ALS techniques. Lay people, first responders, and automated external defibrillator AED users are referred to the adult basic life support and automated external defibrillation section. So this is advanced life support, not basic. Okay, adult ALS includes advanced interventions after basic life support has started and when appropriate an AED has been used. The transition between basic and advanced life support should be seamless as BLS will continue during and overlap with ALS interventions. Post-resuscitation care guidelines are presented in a new section that recognizes the importance of the final link in the chain of survival. These guidelines are based on the International Liaison Committee on Resuscitation (ILCOR) 2015 Consensus on Science and Treatment Recommendations (COSTR) for ALS and the European Resuscitation Council 2015 Advanced Life Support Guidelines. These contain all the reference materials for this section. ALS treatment algorithm. Heart rhythms associated with cardiac arrest are divided into 2 groups: shockable rhythms, which are ventricular fibrillation or pulseless ventricular tachycardia, VF or pulseless VT, and Non-shockable rhythms, which are asystole and pulseless electrical activity, PEA. The main difference in the treatment of these two groups is the need for attempted defibrillation in patients with VF or pulseless VTAC. Okay. Other actions include chest compression, airway management, and ventilation, vascular access, administration of adrenaline, and the identification of correction of reversible factors are common to both groups. The ALS algorithm provides a standardized approach to the management of adult patients in cardiac arrest. Drugs and advanced airways are still included among ALS interventions, but are of secondary importance to early defibrillation and high quality, uninterrupted chest compressions. At the time of writing these guidelines, 3 large randomized controlled trials, adrenaline versus placebo, amiodarone versus lidocaine versus placebo, and supraglottic airway versus tracheal intubation are currently ongoing. So, shockable rhythms, either VF or pulseless VTAC. The first monitored rhythm is VF or pulseless VTAC is approximately 20% of both in-hospital and out-of-hospital cardiac arrests. Ventricular fibrillations or pulseless ventricular tachycardia will also occur at some stage during resuscitation in about 25% of cardiac arrests, with an initial documented rhythm of asystole or PEA. So out of all that present, either at home or at hospital, 20% presents with shockable rhythm. And then if they start with presenting with unshockable rhythm, 25% will change to a shockable rhythm at some point during the resuscitation. That's worth knowing. Treatment of shockable rhythms, VF or VTAC, pulseless VTAC. So confirm the cardiac arrest, check for signs of life and normal breathing, and if trained to do so, check for breathing and a pulse simultaneously. Call resuscitation team. Perform uninterrupted chest compressions while applying self-adhesive defibrillation monitoring pads, one below the right clavicle, and the other in the V6 position in the mid-axillary line, V6 position. So usually you put your V6 over here in your left mid-axillary line beside your apex. Plan actions before pausing CPR for rhythm analysis. Plan actions before pausing CPR for rhythm analysis and communicate these to the team. Stop chest compressions. Confirm VF or pulseless VTAC from the ECG. This pause in chest compression should be brief and no longer than 5 seconds. Resume chest compressions immediately. Warn all rescuers other than the individual performing the chest compressions to stand clear and remove any oxygen delivery device as appropriate. The designated person selects the appropriate energy on the defibrillator and presses the charge button. Choose an energy setting of at least 150 joules for the first shock, the same or a higher energy for subsequent shocks, or follow the manufacturer's guidance for the particular defibrillator. If unsure of the correct energy level for a defibrillator, choose the highest available energy. Ensure that the rescuer giving the compressions is the only person touching the patient. Once the defibrillator is charged and the safety check is complete, tell the rescuer doing the chest compressions to stand clear. When clear, give the shock. After shock delivery, immediately restart CPR using a ratio of 30:2, starting with chest compressions. After shock delivery, immediately restart CPR using a ratio of 30:2, so 30 compressions, 2 breaths, 2 rescue breaths, starting with the chest compressions. Do not pause to reassess the rhythm or feel for a pulse. The total pause in chest compressions should be brief and no longer than 5 seconds. Continue CPR for 2 minutes. The team leader prepares the team for the next pause in CPR. Pause briefly to check the monitor. If VF or pulseless VTAC, repeat steps 6 to 12 above and deliver a second shock. If VF or pulseless VT persists, repeat steps 6 to 8 above and deliver a third shock, 6 to 8. One is 6 to 12, but the other one is 6 to 8. So 6 is resume chest compressions immediately, warn all rescuers other than the individual. Designated person selects the appropriate energy. Ensure the rescuer giving compression only person touching the patient. About 9 to 12. You don't have to shock. And deliver a second shock. And deliver a third shock. So you do have to go up to 12. Resume chest compressions immediately. Give adrenaline 1 mg IV and amiodarone 300 mg IV while performing a further 2-minute CPR. So after the third shock, you want to give adrenaline 1 mg IV and amiodarone 300 mg IV. Remember, adrenaline 1 mg IV and okay. So notice that adrenaline here is IV and not IM. Since this adult advanced life support is not anaphylaxis, you assume that this guy is in hospital, they have IV access. So 1 mg IV, amiodarone 300 mg IV. While performing a further 2-minute CPR. Withhold adrenaline if there are signs of return of spontaneous circulation during CPR. Repeat this 2-minute CPR, rhythm, pulse check, defibrillation sequence if the ventricular fibrillation or pulseless VTAC persists. Give further adrenaline 1 mg IV after alternate shocks. In other words, approximately every 3 to 5 minutes. So after alternate shocks. So one CPR round is 2 minutes. Then you go to shock. After alternate shocks. So every 2 rounds of CPR and shock. If organized electrical activity compatible with cardiac output is seen during a rhythm check, seek evidence of return of spontaneous circulation, check for signs of life, a central pulse, and an end-tidal CO2 if available. If there is ROSC, start post-resuscitation care. If there are no signs of ROSC, continue CPR and switch to the non-shockable algorithm. If asystole is seen, it doesn't say how many times you need to do the CPR before you go to the non-shockable algorithm. If asystole is seen, continue CPR and switch to the non-shockable algorithm. Okay, the interval between stopping compressions and delivering a shock must be minimized. Longer interruptions to chest compressions reduce the chance of a shock, restoring a spontaneous circulation. Chest compressions are resumed immediately after delivering a shock, without checking the rhythm or a pulse, because even if the defibrillation attempt is successful in restoring and perfusing a rhythm, it is very rare for a pulse to be palpable immediately after defibrillation. The duration of asystole before return of spontaneous circulation can be longer than 2 minutes in as many as the duration of asystole before return of spontaneous can be longer than 2 minutes in as many as 25% of successful shock. So successful shock means they will return to spontaneous circulation after that successful shock. But in 25% of people, the return of spontaneous circulation comes only 2 minutes after the successful shock, and that 2 minutes long is an asystole. If a shock has been successful, immediate resumption of chest compressions does not increase the risk of VF recurrence. Okay, so it's safe to continue chest compressions. Furthermore, the delay in trying to palpate a pulse will further compromise the myocardium if a perfusing rhythm has not been restored. The use of waveform capnography can enable return of spontaneous circulation to be detected without pausing chest compressions. The use of waveform capnography, not sure what is that, can enable return of spontaneous circulation to be detected without pausing chest compressions, and may be used as a way of avoiding a bolus injection of adrenaline after return of spontaneous circulation has been achieved, as you want to withhold adrenaline after they have return of spontaneous circulation. Okay, several human studies have shown that there is a significant increase in end-tidal CO2 when return of spontaneous circulation occurs. So capnography, assume you are measuring the level of CO2 in the blood. If return of spontaneous circulation is suspected during CPR, withhold adrenaline. Give adrenaline if cardiac arrest is confirmed at the next rhythm check. Regardless of the arrest rhythm, after the initial adrenaline dose has been given, give further doses of adrenaline 1 mg. Regardless of the arrest rhythm, after the initial adrenaline dose has been given, give further doses of adrenaline 1 mg every 3 to 5 minutes until return of spontaneous circulation is achieved. In practice, this will be about once every 2 cycles of the algorithm. If signs of life return during CPR, for example, purposeful movement, normal breathing, coughing, or there's an increase in end-tidal CO2, check the monitor. If an organized rhythm is present, check for a pulse. If a pulse is palpable, start post-resuscitation care. If no pulse is present, continue CPR. Give amiodarone 300 mg IV after 3 defibrillation attempts, irrespective of whether they are consecutive shocks or interrupted by CPR, or for recurrent VF or positivity during cardiac arrest. Consider a further dose of amiodarone 150 mg IV after a total of 5 defibrillation attempts. Lignocaine 1 mg per kg may be used as an alternative if amiodarone is not available, but do not give lidocaine if amiodarone has been given already. Lidocaine, isn't that a local anesthetic? Local anesthetic. Strange. Let's look at the pharmacology. Its anesthetic is local amides. Lidocaine is used to provide anesthesia by nerve blockade at various sites in the body and in the control of dysrhythmias. It has a rapid onset of action, about 1 minute following intravenous injection and 15 minutes following intramuscular injection, and rapidly spreads through the surrounding tissues. The effect lasts about 10 to 20 minutes and about 60 to 90 minutes following intravenous and intramuscular injection, respectively. So it controls dysrhythmias. Nerve blockade at various sites in the body. So it's both used as an anesthetic and to control dysrhythmias, which is used in case you don't have amiodarone with you. Witness monitored BF PVT, precordial thump, non-shockable rhythms, treatment. Okay. For T's, Is there an algorithm summary here? Anywhere? No. No summary. Oh, here. Adult ALS algorithm. Okay, it should be useful. Okay, so this is much more concise and less detailed, suitable for a medical student. So adult advanced life support. First, the patient is unresponsive and not breathing normally. Call the resus team. CPR, 30 compressions to rescue breath. Attach defibrillator under the right clavicle and the left mid-axillary line beside the apex. Fourth intercostal space, I think. Yes. Attach the defibrillator or monitor. Minimize interruptions. Okay. Your CPR, your compression should not stop for more than 5 seconds. So you stop for less than 5 seconds to assess the rhythm after your CPR. Then, if the rhythm is shockable, give your shock. And immediately resume CPR for 2 minutes. If it's return of spontaneous circulation, do you give immediate post-cardiac arrest treatment? Use ABCD approach. Aim for SpO2 of 94 to 98%. Aim for normal PaCO2. 12 the ECG. Treat precipitating cause. Targeted temperature management. If it's non-shockable, you skip the shock. You immediately resume CPR for 2 minutes. Minimize interruptions. And then there are times. During CPR, ensure high quality chest and compressions, minimize interruptions to compressions, give oxygen, use waveform capnography. This is the one to detect return of spontaneous circulation quickly, so you don't give an adrenaline shot when they have return of spontaneous circulation. Can detect it faster rather than you measuring the pulse. Continuous compressions when advanced airway in place. Vascular access, intravenous or intraosseous. Give adrenaline every 3 to 5 minutes. Give amiodarone after 3 shocks. Right, treat reversible causes. You got hypoxia, hypovolemia. So these are 4 H and 4 T's, I guess. Hypoxia, hypovolemia, hypokalemia, or hyperkalemia, or other metabolic causes, hypothermia, or thrombosis, coronary or pulmonary, tension, pneumothorax, tamponade, toxins. Consider ultrasound imaging, mechanical chest compressions to facilitate transfer treatment, coronary angiography, and percutaneous coronary intervention, extracorporeal CPR. Right, it is a bit too concise, and I want to get back. I'm going to repeat this thing to get it in my head, you know. 1 time's not enough. Okay, shockable rhythms. This is the statistics that we have. So treatment of shockable rhythms. First, you confirm the cardiac arrest, check for signs of life and normal breathing, and if trained to do so, check for breathing and a pulse simultaneously. Call resus team, perform uninterrupted chest compression when applying self-adhesive defibrillation. One below the right clavicle, the other in the V6 position on mid-axillary line. Plan actions before pausing CPR for rhythm analysis and communicate this to the team. Stop chest compressions, confirm VF or PVT from the ECG. This pause in chest compression should be brief and no longer than 5 seconds. Resume chest compressions immediately. Warn all rescuers other than the individual performing the chest compression to stand clear and remove any oxygen delivery device as appropriate, because the spark, you know, the electric shock might cause an explosion to the oxygen. Oxygen is flammable. The designated person selects the appropriate energy on the defibrillator and press the charge button. Choose an energy setting of at least 150 joules for the first shock, the same or a high energy for subsequent shocks, or follow the manufacturer's guidelines for the particular defibrillator. If unsure of the correct energy level for a defibrillator, choose the highest available energy. Ensure that the rescuer giving the compressions is the only person touching the patient. Once the defibrillator is charged and the safety checks complete, tell the rescuer doing the chest compression to stand clear. When clear, give the shock. After shock delivery, immediately restart CPR. using a ratio of 30:2, starting with chest compressions. Do not pause to reassess the rhythm or feel for a pulse. The total pause in chest compression should be brief and no longer than 5 seconds. Continue CPR for 2 minutes. The team leader prepares the team for the next pause in CPR. Pause briefly to check the monitor. So this is the second round already. So first you check this person is unresponsive. So you call the resus team and then you start your compression straight away. 30 compressions, 2 breaths, and shock them. Then continue straight away, don't stop. Don't pause the compressions for too long. So after the shock has been delivered, immediately go back to chest compression. And second round, you're gonna pause after you complete the 30 compressions and 2 breaths. You're gonna pause for less than 5 seconds to check the monitor. So if it's still VF or pulseless VTAC, repeat the steps and deliver a second shock. So after first CPR round, you deliver a shock. And then go with your second CPR round. Then you go for a third CPR round and deliver a second shock. So one round of CPR, shock. The second round of CPR, third round of CPR, then shock again. So it's like after one round of CPR, start the shock, and then every other CPR rounds, you give a shock. If VF of pulses VT persists, repeat steps 6 to 8 above and deliver a third shock. 6 to 8 above. Okay, it seems like it's after the second shock, one CPR round is enough, is it? Maybe the numbering, something wrong. It's quite confusing. Resume chest compressions immediately. Give adrenaline 1 mg IV and amiodarone 300 mg IV while performing a further 2-minute CPR. So after the third shock, during your fourth or fifth CPR round, you're gonna give IV and adrenaline and IV amiodarone. Somebody else has to give, not the person giving chest compressions. With whole adrenaline, there are signs of return of spontaneous circulation during CPR. Repeat this rhythm check, this 2-minute CPR, then rhythm, pulse check, and defibrillation sequence. If VF of pulseless VT persists, I think it's shock every time. Yeah, if it's shockable, you shock every time. I think so. Give further adrenaline 1 mg IV after alternate shocks, approximately every 3 to 5 minutes. If organized electrical activity compatible with cardiac output is seen during a rhythm shock, seek evidence of RSC. If there is RSC, start post-resuscitation care. If there's no signs of RSC, continue CPR and switch to non-shockable rhythm. If asystole, continue CPR, switch to non-shockable rhythm. Adrenaline every 3 to 5 minutes. The interval between stopping compression and delivering shock must be minimized. Longer interruptions to chest compression reduce the chance of shock returning a spontaneous circulation. Chest compressions are resumed immediately after delivering a shock without checking the rhythm or pulse, because even if the defibrillation attempt is successful in restoring or perfusing our rhythm, It is very rare for pulse to be palpable immediately after defibrillation. The duration of asystole before RNC can be longer than 2 minutes, as in as many as 25% of successful shocks. If a shock has been successful, immediate resumption of chest compressions does not increase the risk of VF recurrence. Furthermore, the delay in trying to palpate a pulse will further compromise the myocardium if a perfusing rhythm have not been restored. The use of waveform capnography can enable RSC to be detected without pausing chest compressions and may be used as a way of avoiding a bolus injection of adrenaline after RSC have been achieved. Several human studies have shown that there is a significant increase in end-tidal CO2 when RSC occurs. If RSC is suspected during CPR, withhold adrenaline, give adrenaline if cardiac arrest is confirmed at the next rhythm check. Regardless of the rest rhythm, after the initial adrenaline dose has been given, give further doses of adrenaline 1 mg every 3 to 5 minutes until RSC is achieved. In practice, this will be given about once every 2 cycles in the algorithm. If signs of life returning during CPR are purposeful movement, normal breathing, coughing, or there's increase in end-tidal CO2, check the monitor. If an organized rhythm is present, check the pulse. If a pulse is palpable, start post-resuscitation care. If no pulse is present, continue CPR. Give amiodarone 300 mg IV after 3 defibrillation attempts, irrespective of whether they are consecutive shocks or interrupted by CPR, or for after 3 defibrillation attempts, irrespective of whether they are consecutive shock or interrupted by CPR, or for recurrent VF or VTAC during cardiac arrest. Consider a further dose of amiodarone 150 mg IV after a total of 5 defibrillations. So at 3 defibrillations, you gotta give 1 mg adrenaline and 300 mg amiodarone. 3 rounds of CPR and defibrillation. Then every 3 to 5 minutes after that, you're gonna keep giving adrenaline. So it's after every 2 rounds of CPR, and then after the 5th shock, which is after the 5th round of CPR, you will give another 150 mg of IV amiodarone. If amiodarone not available, give lidocaine 1 mg per kg. Okay. I think it's good enough. Don't want to overload. Where are we now? Already half an hour for one question. So okay, stop.